Welcome to vpod.ai for another deep dive. Today, we're taking a really important look at oral carcinoma. It's complex, no doubt, but understanding how it's treated, the advancements, it's critical stuff. We really want to give you some clear, actionable insights today. But first, just a quick mention of our sponsor, Stonefly. They're a trusted solution provider and advisor, especially if you're dealing with massive amounts of data like in medical research or patient records, that kind of thing. Stonefly offers a whole range of solutions: enterprise storage, backup disaster recovery, hyperconverged setups for VMware, Hyper-V, Proxmox clusters, even AI servers. Plus, they have SA365, which is a turnkey security appliance, and they cover public and private cloud solutions too. So definitely check them out at stonefly.com to learn more about protecting your valuable data.
Okay, so our mission today is to kind of cut through the noise around oral cancer, get straight to the vital info about the disease itself, the treatments, and importantly, how it affects quality of life. We want you to walk away better informed. So let's unpack this.
All cavity squamous cell carcinoma, OSCC for short. It's not just a local problem. It's a major global health challenge. And one big issue is that it often shows up late, at advanced stages, which, well, obviously makes treatment tougher and impacts outcomes. So this deep dive, we're going to cover the whole spectrum: prevalence, causes, treatments, the cutting-edge stuff too, managing those difficult complications from therapy.
Yeah, and what's really crucial to grasp here, I think, is that managing OSCC successfully, it isn't just about targeting the cancer cells. It's about the whole person. It's definitely not a one-size-fits-all situation. It really demands a coordinated team effort. You need surgeons, oncologists, radiologists, dietitians, speech therapists, all working together. It really highlights how intertwined the medical side and the human side are. It needs a personalized approach, one that's always evolving. So yeah, our goal is to give you a really solid understanding of the current strategies, the risk factors, basically help you become much better informed about this complex disease.
Okay, let's start right at the beginning. What exactly are we talking about with oral carcinoma? When we say oral cavity cancer, or OCC, we mean cancers starting in the tissues that line the mouth. And the big one, the most common type by far, is oral squamous cell carcinoma, OSCC. That accounts for something like, nearly 90% of cases.
That's right, almost 90%. It starts in the mucosal epithelium. That's the soft, moist lining inside your mouth. And it can affect various spots: the lips, the inside of the cheeks, that's the buccal mucosa, the roof of the mouth, the hard palate, the front 2/3 of the tongue, the floor of the mouth, the gums or gingiva, and even that little area behind the wisdom teeth, the retromolar trigone.
Right. And it's interesting. You see patterns, don't you? Certain spots are linked to certain risks. Like, I think the side of the tongue is often associated with smoking.
Exactly. The lateral border of the oral tongue, that's frequently linked to cigarette smoking, whereas the buccal mucosa, the inner cheek, you see that more often with chewing tobacco use.
And lip cancer, that's often treated a bit separately, isn't it?
Yeah.
Because the outlook is generally better.
Yeah, traditionally, lip cancer is often analyzed separately in studies. It tends to have a much better prognosis compared to cancers deeper inside the mouth.
Okay, so let's zoom out. What's the global picture look like?
Well, if you connect this to the bigger picture, the global numbers are pretty sobering, actually. Oral cancer accounts for roughly 377,000 new cases every single year worldwide. That's about 2% of all cancers diagnosed. And sadly, it leads to over 177,000 deaths annually, about 1.8% of all cancer deaths.
Wow. And those numbers are going up.
They are. The projections are quite concerning. Estimates suggest we could see a 65% increase in oral cancer incidence by 2050. A huge jump.
And does it affect all regions equally?
No, not at all. There's significant variation. Crude rates can be as low as, say, 1.1 per 100,000 in some African populations, but jump up to 9.9 per 100,000 in Oceania. And there's a really strong link to a country's Human Development Index, the HDI. The projected increase by 2050 is expected to be much, much higher in low HDI countries, around 147.8% compared to very high HDI countries, where it's projected about 34.3%.
So basically, the burden is disproportionately falling on developing nations.
Precisely. It really highlights a massive global health equity issue. There's an urgent need for strategies to tackle this growing number of deaths in low and very low HDI countries. A lot of it comes down to, unequal access to advanced diagnostics and therapeutic options. It's a major challenge.
Yeah, that disparity is stark. So roughly 2/3 of cases are in developing countries.
That's the estimate, yes.
Can you give us some specific regional examples just to paint the picture?
Sure. Look at India, for instance. Oral cancer is the third most common cancer there. In 2012, they had over 77,000 new cases. The male-to-female ratio is about 2.3 to 1, and the mortality is staggering, estimated at over 5 deaths every hour from oral cancer in India.
5 deaths an hour. That's hard to even process. What about other regions, Europe?
Europe actually has the second highest rates after Southeast Asia when you adjust for age. Within Europe, Hungary has recorded the highest mortality and morbidity rates for oral cancer.
Okay, and closer to home, North America. What are the stats here?
In the U.S., it's the 11th most common cancer in men. It accounts for about 3% of male cancers, maybe 2% in women. Projections for 2022 were around 54,000 new diagnoses in Americans. And here's a worrying statistic. About 2/3, 66%, are found at a late stage. That contributes to over 8,000 deaths annually in the U.S. from oral cancer.
Late-stage diagnosis is a huge hurdle. Australia.
In Australia, the incidence is about 6.3 per 100,000 people, again higher in males. Lip cancer has the highest incidence there, while gum cancer, gingival cancer, has the lowest. So you can really see how varied it is globally and how much those regional factors must be playing a role.
Absolutely. Which brings us squarely to the risk factors. What are the biggest drivers, the heavy hitters?
This raises an important question. Yeah, what are the really well-established factors pushing this? And number one, unequivocally, worldwide, is tobacco.
Just smoking. Or
All of it. Cigarettes, cigars, pipes, absolutely. But also smokeless tobacco, chewing tobacco, snuff, snus, and betel quid, which is common in some parts of the world with or without tobacco mixed in. Just using tobacco increases your risk by like 3 to 6 times. It's responsible for maybe 40% of all oral cancers.
how does it actually cause the cancer?
Well, the carcinogens in tobacco directly damage the DNA in your cells. Over time, this damage leads to mutations, and that kicks off the uncontrolled cell growth that is cancer.
Okay, so tobacco is number one. What's next? Alcohol.
Alcohol is definitely another major cause, responsible for maybe 20% of cases globally, and the risk gets seriously amplified when you combine alcohol and tobacco.
Right, I've heard that. How much higher is the risk then?
It's estimated to be about 15 times greater risk for someone who uses both compared to someone who uses neither. 15 times.
Wow, so they work together somehow.
Yeah, it seems alcohol acts kind of like a solvent. It helps the carcinogens from tobacco penetrate the oral tissues more easily. Plus, alcohol itself causes local irritation and inflammation, which isn't good for the cells either. And then there's this compound, acetaldehyde.
Acetaldehyde, what's that?
It's a chemical that forms when alcohol breaks down. Levels of it spike in your saliva right after you drink alcohol. It's produced by bacteria in your mouth, the oral microbiome, and also by enzymes in your mouth lining and salivary glands. Actually, the mouth bacteria are the main source.
So more bacteria, more acetaldehyde.
Potentially, yes. Things like poor oral hygiene, smoking, heavy drinking, they can all increase the bacteria that produce acetaldehyde. And this acetaldehyde is nasty stuff. It reacts with the cells lining your mouth, damages their DNA, and can lead to those cancerous mutations. The body isn't great at clearing it from the mouth quickly, so it can hang around in saliva for hours.
Is that why there's sometimes talk about alcohol and mouthwash being a risk?
Yeah, that's been a point of discussion. The evidence is still somewhat limited, but some studies suggest that very frequent, long-term use of alcohol-based mouthwashes, especially if you also smoke or drink heavily, might increase the risk. It's complex, definitely needs more research. But the general feeling is, well, maybe reducing alcohol in mouthwash is a sensible precaution if possible.
Okay, so tobacco and alcohol are the big two. But are there other, maybe less obvious or emerging factors we should know about?
Absolutely. While tobacco and alcohol dominate, the picture is definitely getting more complex. Other factors are increasingly recognized.
Like what? What about vaping? E-cigarettes, they're everywhere now.
Exactly. Electronic cigarettes or vapes, their popularity has just exploded, especially among younger people. In many places, it's the most common tobacco product used by youth. And even if they don't have nicotine, the liquids and the aerosols they produce contain potentially hazardous stuff.
Like
Solvents like propylene glycol, glycerol, various flavoring chemicals, colorings, artificial sweeteners. It's a chemical cocktail.
So is there a direct link to oral cancer yet?
The direct long-term evidence is still limited. It just hasn't been around long enough for those big studies. But there have been reported cases of OSCC, oral cancer, in young adults who were heavy vapors. And we do see studies linking vaping to similar oral health problems as traditional tobacco, dry mouth, changes in oral bacteria, worse gum disease, problems with dental implants.
So the jury's still out, but caution is advised.
Definitely. It's not risk-free. We need continued monitoring and education about the potential oral risks.
Okay. What about HPV, human papillomavirus? I know it's linked to some head and neck cancers.
Right. High-risk strains, especially HPV-16, are a major cause of oropharyngeal cancers. That's cancers of the tonsils and the base of the tongue further back in the throat. But its role in oral cavity cancers, the ones further forward in the mouth, seems much more limited.
Really? So it's not a big driver there?
Current evidence suggests not as much. A big meta-analysis found HPV in only about 6% of oral cavity cancer cases. And even then, whether it caused the cancer is debated. There's a possibility some base of tongue tumors, which are often HPV positive, might have been misclassified as oral cavity tumors in older studies, kind of muddying the waters. Generally, HPV-linked oral cancers tend to show up in younger people who don't smoke.
Interesting distinction. Okay, what else? I know betel nut chewing is a big thing in some parts of the world.
Huge. Betel nut, sometimes called panean or areca nut, it's a very strong risk factor, even without tobacco added. Chewing betel nut alone can more than double your risk.
And if they add tobacco, like in Gutka,
Then the risk goes up even further, yeah. That practice explains a lot of the high incidence rates we see in places like India and Southeast Asia.
makes sense. Sun exposure.
Yes, definitely for lip cancer, particularly the lower lip. Much more common in people who work outdoors a lot or live in very sunny climates.
Okay. Any other contributing factors?
Yeah, there's a cluster of others. Poor oral hygiene is one. Chronic irritation, maybe from poorly fitting dentures or sharp edges on teeth. Diet plays a role specifically. A diet low in fruits and vegetables seems to increase risk. Genetics and family history can contribute sometimes. Age is a factor. It's more common over 50, although worryingly, we are seeing it rise in younger adults and in women too.
What about people with weakened immune systems?
Yes, absolutely. Immunocompromised individuals, especially those who've had a hematopoietic stem cell transplant, are at higher risk. That can be due to the immune suppression itself, or sometimes a complication called chronic oral graft versus host disease, where the donor immune cells attack the mouth tissues. These cancers can sometimes be more aggressive too.
And finally, those precancerous conditions.
Crucial to mention, things like leukoplakia, those white patches, or erythroplakia, red patches, or a mix, erythroleukoplakia. Also, oral submucous fibrosis, which is related to betel nut, and actinic cheilitis on the lips from sun damage. These aren't cancer yet, but they have the potential to transform into it over time, so they need close monitoring.
Wow, okay. So a lot of different potential contributors there.
So what does this all mean? It really underscores that prevention is key. And prevention mainly means tackling those known risk factors we just laid out. The single most effective thing anyone can do is avoid tobacco. Full stop. All forms.
Quitting makes a real difference.
Absolutely. Quitting cigarettes, cigars, pipes, smokeless tobacco, betel quid, it's crucial. And even if someone's already been diagnosed, quitting smoking still matters hugely. Continuing to smoke slows recovery and seriously bumps up the risk of the cancer coming back or getting a new second cancer.
And alcohol.
Limiting alcohol intake, especially if you also quit tobacco, significantly lowers the risk. The combined effect is powerful.
Simple things too, like lip protection.
Yep. Using lip balm with SPF, avoiding excessive sun, it makes a difference for preventing lip cancer. These lifestyle changes are really powerful tools.
What's fascinating here is sometimes it's the simpler steps that have surprisingly big impact, like vaccination.
Exactly. The HPV vaccine can significantly reduce the risk of those HPV-related cancers, particularly the ones further back in the oropharynx. Its direct impact specifically on oral cavity cancers is maybe less pronounced because HPV plays a smaller role there, but it's still a vital preventative tool overall for head and neck cancers, especially for younger people before exposure.
Okay, and then there's the thing we probably all know we should do, but maybe underestimate its importance. Oral hygiene and dental visits.
Cannot overstate this one. Good oral hygiene brushing, flossing, and regular dental checkups are critical. Why? Because dentists are often the very first people to spot something suspicious, an unusual sore, a white patch, a red patch. They can catch oral cancer or precancerous lesions early during a routine exam.
So those checkups are really screening opportunities too.
Absolutely. And getting a really thorough oral health exam before starting any cancer treatment is also vital.
Why?
Because it gives time to fix any existing problems. Cavities, gum disease, bad fillings. You want the mouth as healthy as possible before treatments like chemo or radiation start, as those can really exacerbate problems. It helps prevent or lessen nasty complications down the line, like severe mouth sores, infections, or tooth decay during therapy. That pre-treatment check looks for everything: existing sores, decay, gum issues, denture fit, even jaw movement and salivary gland function. Simple steps, big impact.
Okay, so prevention is key, early detection is key. But what happens when something is found? How does that diagnostic process actually work? It sounds like it becomes a team effort pretty quickly.
That's exactly right. The journey of diagnosing and staging oral cancer, it really is a multidisciplinary effort right from the start. It's all about getting the initial diagnosis correct, figuring out the exact stage of the cancer, and then planning the best treatment path. It typically kicks off with a detailed medical history and a very thorough clinical exam of the mouth and neck.
And then the biopsy. That confirms it.
Yes, the biopsy is the definitive diagnostic step. A small piece of tissue is taken from the suspicious area. This can be done in a few ways: a scalpel biopsy, a punch biopsy, sometimes a needle aspiration if it's a lump. It's worth noting those brush biopsies, where they just scrape cells. They generally aren't considered accurate enough for a definite cancer diagnosis. You need a tissue sample.
Okay, so the pathologist looks at that tissue.
Correct. The pathologist examines it under the microscope. They confirm if it's cancer, usually squamous cell carcinoma. They also provide crucial details: how abnormal the cells look, how fast they're dividing, and really importantly, the depth of invasion, how far the cancer has grown into the underlying tissue. And often, the HPV status, too.
Depth of invasion. That sounds key.
It is. We'll come back to that with staging. So once cancer is confirmed, the next step is staging, figuring out the extent of the disease. Has it spread? How far? This involves imaging.
Like CT scans, MRIs.
Exactly. CT scans, MRIs, often a PET scan too. These help visualize the tumor size, see if it's grown into nearby structures like bone. Sometimes a panendoscopy might be recommended.
Panendoscopy. What's that?
It's basically using scopes to get a detailed look at the entire upper airway and digestive tract, nasal cavity, pharynx, larynx, esophagus, even the top of the lungs. The reason is, all of these areas are exposed to the same potential carcinogens, like smoke. So there's a higher risk of having another separate primary cancer in those areas, and you want to find it if it's there.
Ah, okay. Makes sense. Other tests for spread?
Yeah, things like a chest x-ray or maybe other scans to check for distant spread, like to the lungs. And sometimes more invasive tests are needed, like sampling lymph nodes with a needle or doing a sentinel lymph node biopsy, which we should definitely talk more about. The goal of all this staging workup is to pinpoint the exact location and size of the tumor, identify which lymph nodes might be involved, their size, and crucially whether the cancer has broken out of the lymph node capsule. That's called extranodal extension, or ENE.
ENE. Why is that so important?
Because ENE is a sign of more aggressive disease. It heavily influences the treatment plan and the patient's prognosis.
Well,
Getting all these details right is fundamental.
okay. If we connect this to the bigger picture,
Yeah.
understanding this staging, it sounds absolutely critical for figuring the prognosis and the treatment plan, right?
Right.
You mentioned the TNM system.
Exactly. The TNM system is the universal language doctors use to classify the stage of oral cavity squamous cell carcinoma, TNM.
So T is for tumor. What does that tell us?
Right. T describes the primary tumor itself. It considers the tumor's size, but even more critically, as we mentioned, its depth of invasion, DOI. How deep has it grown into the tissue?
So a deeper tumor is worse, even if it's small.
Yes. DOI is a major factor. Each millimeter deeper significantly increases the risk that the cancer has spread to lymph nodes. So a small tumor that's deeply invasive might be staged higher and treated more aggressively than a larger but very superficial one. The T stages range from TIS, carcinoma in situ, just on the surface, up to T4B, which means very advanced invasion into surrounding structures like the jawbone, skin, or major arteries.
Okay, that makes sense. Then N is for nodes, lymph nodes in the neck.
Correct. N describes whether the cancer has spread to the regional lymph nodes in the neck. It looks at if nodes are involved, how many, their size, whether they're on the same side as the tumor, ipsilateral, the opposite side, contralateral, or both bilateral. And crucially, it incorporates that ENE status extranodal extension. Has the cancer broken through the capsule of the lymph node?
So N0 means no nodes involved.
Right. N0 is no spread to lymph nodes. Then it goes up to N3, which indicates more extensive node involvement, either very large nodes, multiple nodes, nodes on both sides, or nodes with that clinically obvious ENE.
That ENE sounds like a real red flag.
It is. It significantly worsens the prognosis and usually means more intensive treatment is needed.
Okay, T for tumor, N for nodes. M must be.
M is for metastasis, distant metastasis. Has the cancer spread to faraway parts of the body, like the lungs, liver, or bones? M0 means no distant spread. M1 means distant metastasis is confirmed.
And then you combine T, N, and M to get the overall stage.
Exactly. The T and M findings are combined to assign a prognostic stage group. This ranges from stage 0, the earliest, TIS, up through stage IVC, distant metastasis. Stage I is typically a small tumor, no nodes, no metastasis. Stage 5 represents the most advanced disease, large tumors invading nearby tissues, extensive lymph node involvement, or distant spread. It can also include recurrent cancer.
And the higher the stage, generally the tougher the outlook and the more likely it is to come back.
That's generally true, yes. Stages 3 and 4 in particular have a significantly higher risk of recurrence compared to early stage disease. This staging is just fundamental for guiding every treatment decision.
So once you have that diagnosis and stage, the focus shifts to treatment. You said surgery is often the main approach for non-metastatic OSCC.
Yes, ideally, for OSCC that hasn't spread distantly, surgery is the primary curative treatment.
And that decision, it's made by a whole team.
Absolutely. It's always a multidisciplinary team discussion. Surgeons, radiation oncologists, medical oncologists, pathologists, radiologists, speech therapists, dietitians. Everyone weighs in to create the best plan for that specific patient. The goal, especially for early-stage disease, is always to use the least invasive surgical approach that can still achieve a cure to minimize the impact on function and quality of life.
You mentioned managing the neck lymph nodes is critical. Why is that so central?
Because whether or not cancer has spread to the neck nodes has a huge impact on survival. Even in patients with early-stage tumors, where we can't feel or see any involved nodes on scans, what we call clinically node-negative or CN0, there's still a chance of hidden spread. Occult metastasis.
How common is that hidden spread?
It can be present in up to 20–30% of those early-stage, apparently node-negative patients. So traditionally, to address this risk, an elective neck dissection, END, has been recommended for tumors with a depth of invasion over about 3 millimeters. That means removing lymph nodes from the neck as a precaution.
But does that always find cancer?
Well, here's the catch. In up to 80% of patients who undergo an NE for early-stage OSCC, the removed lymph nodes actually turn out to be negative for cancer.
So a lot of people might be getting a bigger surgery than they strictly needed.
Potentially, yes.
Yeah.
And neck dissection has its own risks and side effects, shoulder dysfunction, numbness, scarring. Which leads us to a really important development, sentinel lymph node biopsy, or SLN biopsy.
Okay, SLN biopsy. How does that work? Is it less invasive?
It is. It's a diagnostic procedure, not a full neck dissection initially. It's already standard practice for cancers like melanoma and breast cancer. The idea is to identify and remove only the first lymph node or nodes, the sentinels, that drain fluid directly from the primary tumor site.
And if those are clear?
If the sentinel nodes are negative for cancer after careful examination by the pathologist, the theory is that it's highly unlikely the cancer has spread further into the neck. So the patient can potentially avoid the full elective neck dissection.
What are the advantages of SLN biopsy over the traditional ED?
Several potential benefits. It might reduce morbidity, fewer side effects like shoulder problems. It could be more cost-effective. Studies show it has a very high negative predictive value, meaning a negative result is very reliable. This allows around 70% of early OSCC patients to safely avoid a complete neck dissection. Survival outcomes appear to be equal to end, but with potentially shorter hospital stays. Plus, it can sometimes identify unusual drainage patterns, finding sentinel nodes in unexpected locations that a standard ND might miss.
Is it suitable for everyone with early-stage OSCC?
Not necessarily. Patient selection is key. It might not be ideal for patients with many other health problems who might need a full dissection later anyway, or if they can't commit to the close follow-up required. Tumor location also matters. It's best for tumors that can be removed without needing wide access to the neck for reconstruction, for instance. The technique itself requires specialized training for both the surgeon and the pathologist to ensure accuracy.
So what happens after the SLN biopsy?
If the sentinel node come back positive for cancer, even tiny amounts, micrometastases, then a completion neck dissection to remove the remaining nodes is usually recommended. If the SLN biopsy is negative, the patient typically enters an active surveillance protocol, regular clinical exams and imaging, maybe every 3 months initially, to watch closely for any signs of recurrence. There's growing evidence supporting SLN biopsy as a safe and effective alternative to N for carefully selected early-stage OSCC patients, offering comparable cancer control with potentially less impact on the patient.
Okay, so surgery is primary, but
Sometimes it's not the first step, or maybe not the only step needed.
This raises an important question.
Exactly.
When is surgery not the primary option? Or when do patients need something in addition to surgery? This brings us to definitive radiation therapy, sometimes combined with chemotherapy, what we call non-operative management. This is considered when upfront surgery isn't really feasible.
Why wouldn't it be feasible?
Could be several reasons. Maybe the cancer itself is just too extensive, or in a location that makes complete removal impossible or extremely damaging. That's cancer-related. Or it could be patient-related. Maybe the patient refuses surgery, or they have other serious health conditions that make a major operation too risky. Or sometimes the surgery required would cause such significant functional or cosmetic problems that radiation becomes the preferred primary approach, treatment-related.
So in those cases, radiation or chemoradiation is the main treatment. How effective is that?
Outcomes can vary quite a bit based on older studies, reflecting differences in patient selection and techniques. Some show good local control, others less so. Generally, for early-stage OSCC, if surgery is feasible, it tends to offer better outcomes than primary radiation alone. But when surgery isn't an option, definitive radiation or chemoradiation is certainly a reasonable alternative curative approach.
Okay. And what about treatment after surgery? Adjuvant therapy.
Right. Adjuvant treatment means therapy given after the primary surgery to reduce the risk of the cancer coming back. This usually involves radiation, or T-dish, or chemoradiation, CRT. Patients are typically stratified into risk groups based on what the pathologist finds in the surgical specimen.
Risk groups, like low, medium, high.
Essentially, yes. Low-risk patients usually don't need any adjuvant therapy. Intermediate-risk patients, those with certain adverse features found during pathology, like cancer cells close to the edge of the removed tissue, or invading nerves, usually need postoperative radiation therapy, CORT. And then the high-risk group patients with positive surgical margins, cancer cells right at the edge, and ended or that extranodal extension, ENE, we talked about, they typically require postoperative chemoradiation, CRT, combining radiation with chemotherapy, usually cisplatin. This tailoring of post-op treatment based on risk is crucial for improving outcomes.
Okay, let's talk about recurrence. It's obviously a major concern after treatment. What happens if the cancer comes back, especially if it comes back quickly?
Yeah, recurrence is a significant challenge, and early local regional recurrence, LRR, meaning the cancer comes back in the original area or nearby neck nodes relatively soon after surgery, sometimes even before planned adjuvant radiation can start. That's particularly worrying.
Why is early recurrence so bad?
It indicates very aggressive disease biology and is generally associated with poor outcomes. Certain factors increase the risk of early LRR, having the primary tumor in the oral tongue, having a larger tumor, PT3-4, or more extensive node involvement, PN2-3 initially, or having microscopic cancer cells left at the surgical margin.
Can it be hard to detect right after surgery?
It can be very challenging. There's post-surgical swelling and changes, making clinical detection difficult, and investigating suspected recurrence can delay starting necessary postoperative radiation. So for patients identified as high risk for early LRR, getting postoperative imaging, like an ultrasound of the neck, maybe around 4 weeks after surgery, before radiation planning, can be really helpful to catch it early.
And if early recurrence is found, what then?
If it's confirmed, usually with a biopsy, then intensified treatment strategies are needed. This is called salvage treatment. It might involve more surgery if possible, or using higher doses or accelerated schedules of radiation, often combined with concurrent chemotherapy. Some studies show these intensive salvage approaches can be successful in a proportion of patients, maybe around 36% achieving 5-year survival, though it's definitely a tough situation.
Okay, that's local recurrence. What about spread to distant parts of the body? Metastasis.
Distant metastasis, DM, is another major concern, especially as we get better at controlling the cancer locally in the head and neck. The overall incidence of DM in OSCC is somewhere between 5% and 15%.
What makes distant spread more likely?
Predictors include things like patient age, the initial T and N stage, more advanced stages have higher risk, the tumor's histological grade, how aggressive the cells look, whether cancer cells invaded blood vessels or lymph channels, lymphovascular invasion, and again, that ENE status.
So can we screen for it better in high-risk patients?
That's the idea. Developing risk-adaptive screening protocols using imaging to try and detect DM earlier, especially when it might be limited to just a few spots, what we call oligometastases.
Oligometastases.
Right.
Just 1 or 2 spots in the lungs.
Exactly. If you can find these early, sometimes aggressive local treatments like highly focused radiation, SBRT, to a lung spot, or surgically removing it can actually improve survival compared to just starting systemic therapy for widespread disease. There's also ongoing research into using newer, multi-drug systemic therapies, perhaps even upfront as induction chemotherapy before local treatment, specifically for patients at very high risk of developing DM to try and prevent it from happening. Some studies have shown hints that induction chemo might reduce DM rates.
Induction chemo, giving chemo before surgery. Does that have alpha?
It's used in certain situations, and one fascinating area where it's being explored is for mandible preservation.
Ah, saving the jawbone. That sounds incredibly important for quality of life.
Absolutely. Having to remove part or all of the mandible, the lower jawbone, has huge long-term consequences. Speech, swallowing, appearance, overall quality of life, it's all significantly impacted. So the idea behind using induction chemotherapy here isn't to replace surgery, but potentially to shrink the tumor before surgery.
To make it small enough to remove without taking the jawbone.
Exactly. To facilitate a less extensive surgery that preserves the mandible rather than requiring a major resection and reconstruction. There's evidence, including meta-analyses, suggesting induction chemo can reduce distant metastasis risk across head and neck cancers. And specific studies looking at OSCC invading close to the mandible have shown some encouraging results with certain chemo regimens, like DCF, docetaxel cisplatin 5-fluorouracil, in achieving mandible preservation.
Is DCF the standard for this?
It's generally considered one of the more effective regimens for tumor shrinkage in this setting. An important point is surgical margins after chemo. Studies suggest you can base the resection on the post-chemo tumor size, and if followed by appropriate adjuvant chemoradiation, the outcomes can be good.
But induction chemo must have side effects.
Oh, definitely. Especially the DCF regimen, it can cause significant toxicities. Severe side effects are, unfortunately, quite common. The full impact on quality of life needs more study, too.
So it's a potential option, but needs careful consideration.
Precisely. It might be a strategy for preserving the jaw in locally advanced OSCC, where mandibulectomy would otherwise be needed if the tumor isn't clearly eroding the bone on scans. But it requires using something like 3 cycles of DCF, followed by surgery, followed by adjuvant chemoradiation. It has to be a very carefully selected patient with extensive multidisciplinary discussion and the patient fully involved in understanding the trade-offs between potential organ preservation and increased treatment toxicity.
Okay, that makes sense. Now, shifting back to that adjuvant therapy after surgery, you mentioned high-dose cisplatin with radiation is the standard for high-risk patients.
That's right. Postoperative concurrent chemoradiation, CRT, with high-dose cisplatin, usually 100 millimeter every 3 lets, is the proven standard of care for high-risk OSCC, those positive margins or E&E cases. It improves local control, disease-free survival, and overall survival.
But it's a tough treatment.
It is. It comes with significant side effects, both acute and long-term. Hearing loss, ototoxicity, kidney damage, nephrotoxicity are major concerns. And the reality is a lot of patients just aren't eligible for high-dose cisplatin because of their age, other health problems, or kidney function. They're platinum ineligible.
So what are the alternatives? Let's start with patients who can tolerate platinum, but maybe not the high dose every 3 weeks. Are there other platinum options?
People have tried lower doses of cisplatin given weekly. Initially, it seemed like a good compromise, maybe less toxic, but still effective. However, larger studies comparing weekly versus every 3 weeks high-dose cisplatin found that while weekly might be non-inferior for overall survival in some analyses, it sometimes led to worse local control and still had considerable side effects. So it's not a clear win.
What about other drugs for platinum-fit patients?
Carboplatin, another platinum drug, hasn't shown added benefit when combined with radiation in this setting. Cetuximab, a targeted therapy, also didn't pan out for platinum-eligible patients needing CRT. Even adding immune checkpoint inhibitors like avelumab or pembrolizumab to standard CRT failed to improve outcomes in recent big trials. Right now, maybe the most promising data for an alternative combination in platinum-fit patients might involve docetaxel plus cetuximab, but more research is needed. Some large studies also hinted that for the very highest risk patients, advanced TN stage with E&E, intensifying treatment either by adding chemo or by accelerating the radiation schedule might provide the biggest survival benefits.
Okay. Now, what about defining who is actually ineligible for cisplatin? It's not always clear-cut, is it?
No, it's a spectrum. There are absolute contraindications, things that definitely rule it out, like very poor overall health, ECOG performance status 3-4, severe kidney dysfunction, creatinine clearance less than 50 millimine, significant hearing loss or nerve damage already present, grade 2 or higher, a known allergy to platinum drugs, or being pregnant lactating. Also, conditions like advanced HIV/AIDS with very low CD4 counts.
And then there are relative reasons, where it's
Yeah.
more of a judgment call.
Exactly. Relative contraindications might include slightly poorer performance status, ECOG-2, being older, over 70, though now we rely more on geriatric assessments than just age, borderline kidney function, clearance 50-60 millimole mean, having other significant health problems, having received a lot of platinum chemotherapy before, significant weight loss, or taking other drugs toxic to the kidneys. These factors mean the risks of cisplatin might outweigh the benefits.
So for those patients deemed platinum unfit, what are the best alternatives to combine with radiation?
This is a really critical area of research. We know carboplatin probably isn't effective here. The strongest evidence currently points towards using docetaxel, another type of chemotherapy, given once weekly at a dose of 15 mg/meter alongside postoperative radiation. A study called DHNUF specifically showed the significantly improved both disease-free and overall survival compared to radiation alone in platinum-ineligible patients, even frail ones with manageable side effects.
So weekly docetaxel is a key option there. Any others?
Other possibilities explored include using concurrent cetuximab with radiation, combinations like carboplatin 5-FU or carboplatin paclitaxel, or just using an accelerated radiation schedule without chemo. The evidence for these is generally less robust than for weekly docetaxel in the unfit setting. And there's exciting future research. A new drug called zavitapant, which works by blocking proteins that inhibit cancer cell death, is being tested in large clinical trials specifically for cisplatin-ineligible patients receiving postoperative radiation. That could be a game changer if it proves effective.
It's clear finding effective, tolerable options for everyone is a huge priority.
Absolutely. Now, shifting gears slightly, but critically related treatment. Let's talk about the oral complications.
Right. If we connect this to the bigger picture,
Yeah.
these complications are incredibly common, aren't they? Especially with head and neck cancer treatments.
Extremely common, and they're not just minor side effects. They can seriously impact a patient's ability to get through treatment, their quality of life long after, and even lead to other health issues.
Why do they happen so often with these treatments?
Well, think about what chemotherapy and radiation are designed to do. Target rapidly dividing cells. Cancer cells divide rapidly, but so do the healthy cells lining the mouth and the entire digestive tract. So these treatments inadvertently damage those healthy cells, slowing down their ability to repair themselves. This leads to breakdown, inflammation, sores. Radiation, especially when aimed at the head and neck, directly damages the oral tissues, salivary glands, and even the bone in the jaw. Both chemo and radiation can also disrupt the normal, healthy balance of bacteria in the mouth. This imbalance, combined with the damaged tissues, creates a perfect storm for infections, sores, and tooth decay.
So it's a direct hit on the tissues and disrupts the mouth's ecosystem.
Precisely. Which is why managing these potential complications requires that multidisciplinary team approach we mentioned earlier: the oncologist, dentist, nurse, dietitian, speech therapist, social worker. Everyone needs to be involved in planning care to anticipate and manage these issues.
Okay, let's unpack some of these common complications.
Yeah.
It sounds like they can really impact day-to-day life profoundly.
They absolutely can. Decreased shipment tolerance, lower quality of life, risk of other health problems. It's a cascade effect.
What's one of the most common ones? Mouth sores.
Yes, oral mucositis, sometimes called stomatitis. This is inflammation and painful ulceration of the mucous membranes lining the mouth. If it's caused by chemotherapy, it usually heals within about 2 to 4 weeks after the chemo stops. But radiation-induced mucositis can last much longer, maybe 6 to 8 weeks. Patients getting stem cell transplants often get it starting 7-10 days after, lasting maybe 2 weeks post-treatment. It can cause severe pain, make eating incredibly difficult, increase infection risk, cause bleeding, and sometimes even affect breathing.
Infections sound like a big risk, too, with the immune system down.
Definitely. The damaged oral lining plus a weakened immune system, low white blood cell counts from chemo, makes patients very vulnerable to infections. Bacterial, fungal like candida or thrush, or viral like herpes flare-ups. Dry mouth also makes infections more likely.
And pain, is that just from the sores?
Pain can come from many sources. The mucositis sores are a big one, but also directly from the tumor, nerve irritation, inflammation, or even as a side effect of surgery. Sometimes it's referred pain, felt in the mouth, but starting elsewhere.
What about dry mouth? That seems like it would affect everything.
Dry mouth, or xerostomia, is incredibly common and often debilitating, especially after radiation. Radiation therapy frequently damages the salivary glands, sometimes permanently, so they just don't produce enough saliva. Chemo-induced dryness is usually temporary.
What problems does dry mouth cause?
Lots. Increased thirst, obviously, but also significant changes in taste, difficulty swallowing and speaking, a constant burning sensation, cracked lips, problems wearing dentures, and a much higher risk of tooth decay and infections because saliva normally helps protect the teeth and cleanse the mouth.
Case changes too.
Yes. Taste changes, dysgeusia, are very common with both chemo and radiation. Food can taste metallic, bland, or just wrong. It can be temporary, but often permanent after radiation.
With all that difficulty eating and tasting, malnutrition must be a risk.
Huge risk. Malnutrition and dehydration often result from loss of appetite, pain, dry mouth, and difficulty swallowing.
Bleeding.
Bleeding can happen if chemo lowers the platelet count, which affects blood clotting. Gums might bleed easily.
What about physical changes like stiffness?
Mouth and jaw stiffness, called trismus, can happen after surgery or as a late effect of radiation. Radiation causes fibrosis, a kind of scarring, in the skin, muscles, and joints. This makes it hard to open the mouth widely, impacting eating, speaking, and even brushing teeth.
And swallowing problems.
Swallowing problems, dysphagia, are very common before, during, and after treatment. It increases the risk of food going down the wrong way, aspiration pneumonia, leads to poor nutrition, and often requires feeding tubes. It can be temporary or permanent.
All this increases risk for dental problems too, right?
Absolutely. Tooth decay and gum disease risk goes way up due to dry mouth and changes in oral bacteria. And finally, there can even be tissue and bone loss. Radiation can damage the tiny blood vessels supplying the jawbone, leading to bone death osteonecrosis. This is a serious complication causing pain and potential fractures. Radiation can also damage soft tissues, causing painful ulcers that don't heal well.
Wow, that's a lot to potentially deal with. It really highlights the need for proactive management.
This raises an important question. Exactly. How do we mitigate these challenges and support patients effectively? Prevention and management are key, and they start before treatment even begins.
Before treatment, what can be done then?
A comprehensive oral health exam is step one. Treat everything before starting cancer therapy, cavities, broken teeth, gum disease, ill-fitting dentures. Get them out as healthy as possible. Good baseline oral care habits, healthy diet, meticulous brushing and flossing are also important. And for head and neck patients, quitting smoking is paramount.
Okay. And then during and after treatment, what are the key strategies?
Regular, gentle oral care is non-negotiable. Soft bristle brush, fluoride toothpaste 2-3 times a day. Frequent rinsing, maybe with a supple salt and baking soda solution, or prescribed antibacterial rinses. Gentle flossing if possible. Keeping lips moisturized with water-soluble lubricants.
How do you manage the mucositis pain?
For mucositis, keep the mouth clean, maybe rinsing every 4 hours. Use lubricating jellies. Mild rinses help. Pain relief can come from topical numbing agents, prescribed painkillers, but avoid NSAIDs like ibuprofen during chemo due to bleeding risk. There's some evidence zinc supplements might help with radiation-induced pain.
What about general pain control?
First, diagnose the cause. Then use topical treatments, appropriate painkillers. Opioids might be needed for severe pain. But also non-drug methods can be very helpful. Physical therapy, 10NS units, cold heat packs, hypnosis, acupuncture, distraction techniques, relaxation, cognitive behavioral therapy, CBT, even music or drama therapy, counseling.
How are infections treated?
Infections need specific treatment. Medicated rinses. Antibiotics for bacterial infections. Antifungal drugs, mouthwashes, lozenges, or sometimes pills for fungal infections like candida. Antiviral drugs if it's a herpes virus flare-up.
And bleeding.
For bleeding, continue good oral care to prevent infection, which can make bleeding worse. Doctors might use medicines to help clotting or reduce blood flow, or topical products applied directly. Salt water or diluted hydrogen peroxide rinses might be suggested sometimes.
Dry mouth seems like a tough one to manage long term.
It is. Dry mouth care involves constant vigilance, frequent cleaning, using high fluoride toothpaste or gels, frequent rinsing or sipping water, avoiding sugary foods and drinks. Saliva substitutes can provide temporary relief. There are some medications that can stimulate saliva production in certain cases. Acupuncture has also shown some promise here.
How do you address the malnutrition risk?
Malnutrition management often requires dietary changes, chopped, pureed, or blended foods that are easier to swallow. High-calorie, high-protein snacks and supplements are key. Often, formal nutrition support, like liquid diets or even feeding tubes, gastrostomy tubes, are necessary, especially for patients getting combined chemo and radiation.
What about the stiffness and swallowing issues?
Jaw stiffness, trismus, is managed with specific medical devices, pain treatments, sometimes muscle relaxers, and crucially, jaw stretching exercises. Swallowing problems, dysphagia, require a team approach involving speech therapists for swallowing therapy and exercises, dietitians for texture-modified diets, sometimes dental specialists for prosthetic devices, and psychologists for coping strategies.
And the bone loss risk, osteonecrosis.
Preventing tissue and bone loss involves maintaining good nutrition, avoiding tobacco and alcohol. If osteonecrosis occurs, treatment might include topical antibiotics, pain control, sometimes surgery to remove the dead bone, and maybe hyperbaric oxygen therapy to improve healing. It's complex.
So, a very comprehensive toolkit is needed. Are there other special considerations, maybe for certain types of treatment?
Yes, there are. Patients undergoing high-dose chemotherapy and/or stem cell transplantation face unique challenges. They have a higher risk of graft versus host disease, GVHD, where the donor immune cells attack the recipient's body, often affecting the mouth, causing severe sores, dryness, pain, and swallowing problems. GVHD treatment involves things like special topical rinses or gels, antifungals, sometimes even light therapy called PUVA. These patients also need special care for any oral devices like braces or dentures they might need to be removed or adjusted. Oral hygiene has to be incredibly strict. Sometimes specific medicines or even sucking on ice chips during chemo infusion are used to try and prevent mucositis. Dental treatments are usually delayed until the immune system recovers, which can take 6-12 months post-transplant.
Any other long-term risks after these intense therapies?
Unfortunately, yes. Survivors are at risk for developing second cancers later in life. This includes oral squamous cell cancer, especially on the lips or tongue, which is seen more often in transplant survivors.
And there's another type of jawbone issue separate from radiation.
Right. Osteonecrosis of the jaw, O&J. This is bone loss and infection, but it's not directly caused by chemo or radiation. It's linked to certain drugs used to treat cancer that has spread to the bones or other bone conditions like osteoporosis. These drugs include bisphosphonates and denosumab, and sometimes angiogenesis inhibitors. It's a known potential side effect of those specific medications.
And what about children? Complications must affect them differently.
They can. Oral complications in children undergoing cancer treatment can interfere with normal dental growth and development. This might lead to teeth coming in late or not at all, teeth being smaller than normal, or incomplete development of the face and jaw. Long-term dental follow-up is crucial for these kids.
We've focused a lot on the physical side, which is obviously huge. But what about the emotional and social impact of all these complications?
So what does this all mean? Beyond the physical pain and discomfort, the psychosocial impact is immense. It really can't be overstated. Imagine struggling to eat comfortably at a family dinner or finding it difficult to speak clearly in a conversation. These fundamental human activities become sources of frustration, embarrassment, and anxiety. This can easily lead to withdrawal from social situations, feelings of isolation, depression. Quality of life takes a major hit when basic functions like eating and speaking are compromised.
So supportive care is about more than just physical symptoms.
Absolutely. Supportive care from the healthcare team, family, and friends is vital for helping patients cope with these emotional and social challenges. And patient support organizations play a critical role here. Groups like SBOHNC, that support for people with oral and head and neck cancer, are invaluable. SBOHNC is a nonprofit dedicated to raising awareness and providing resources, education, and crucially, peer support. They connect patients and caregivers, helping them share experiences, learn coping strategies, and feel less alone. It's about supporting the whole person physically and emotionally through this incredibly challenging journey.
This has been a really thorough deep dive. We've covered so much ground on oral carcinoma, from its significant global impact and regional variations to the complex web of risk factors, the big ones like tobacco and alcohol, but also emerging concerns like vaping, HPV's role, betel nut. We looked at prevention, lifestyle, vaccination, the absolute importance of oral hygiene, and those dental checkups for early detection. In the diagnostic path, understanding staging with TNM and how that guides everything. And the treatments themselves, the advances in surgery like SLM biopsy, the role of radiation and chemoradiation, strategies for recurrence, innovations like trying to preserve the mandible, and the ongoing search for better, safer adjuvant therapies, especially for platinum ineligible patients. And finally, tackling those very real, often difficult oral complications, both physically and psychosocially. It's a lot. Before we wrap up, I just want to circle back quickly to our sponsor, Stonefly. Especially thinking about all the data involved in research and patient care we've discussed, having secure storage is paramount. Stonefly is currently offering a really powerful solution.
a 100 TB immutable and air-gapped SSO NAS for just $8,995. That kind of setup is fantastic for protecting critical data against threats like ransomware, ensuring it's secure and resilient, which is incredibly relevant in fields like healthcare. You can find all the details on that offer and their other solutions at stonefly.com. Really practical, tech-supporting vital work. Okay, so after covering all of this, what's the final thought you want to leave our listeners with?
Yeah, this raises an important question, I think. We've talked a lot about the complexities, the treatments, but we also heard that for early diagnosed cases, the survival rates can be really high, over 90%. So knowing that early diagnosis makes such a drastic difference, the question becomes, how can we as individuals, as communities, maybe even as healthcare systems, redefine what a routine checkup means? Should we be thinking beyond just dental health towards prioritizing comprehensive oral cancer screenings for everyone, even people who don't think they have obvious risk factors? It's something to ponder. How do we shift the paradigm towards catching this potentially devastating disease much earlier when the chances for cure are so much better? It puts some agency back in our hands, both personally and collectively.